I would request Dr. Aarya Bharadwaj to help us understand more about observational study design. She has completed her BDS and MDS in public health dentistry in Vokkaligara Sangha Dental College and Hospital, Bengaluru. She has been a resident in 3 dental colleges and health centers. She has conducted annual school oral health programs for 3 successful years at 6 schools in Bengaluru. She has been awarded the Best Paper Award at 23rd IA National Conference, Ghaziabad. She has completed several certificate courses, including COVID-19 contact tracing at Johns Hopkins School of Public Health. She has actively taken part in conference presentations at IAPHD National Conference and IAPHD National Convention. I would request Dr. Aarya ma'am to please stand.
One second. Is my screen visible?
Yes, ma'am.
Yeah. A very good morning to everyone here. Before I begin, I would like to thank Dr. Vinny and the entire team associated with P-Value for giving me this opportunity, and I hope um, I'm able to I'm able to make you guys understand what observational study designs are, and you can take away or go back with a much clearer understanding and with much more confidence to do an observational study. So moving ahead, my topic is the research snapshot. So it's very aptly put, it's called a snapshot because
Madam, we are not able to see your screen.
yeah, one second. Give me a second. Is this visible?
Yes, ma'am.
Yeah, okay. So, very aptly put, it's a snapshot. So, it's basically giving us an idea as to what is the situation out there. What is the situation out there, and how we understand what's happening, and this is what is going to pave way to what we can do next. So the whole idea of using the term snapshot is also because we do not intervene in any observational study. You as an investigator do not take part in altering the disease progression or providing some sort of intervention or treatment to the individual. You are just standing there as a mute spectator, watching, observing, and noting down in order to disseminate the findings. It's only when you come to the interventional or experimental study designs where you actively involve in modifying the disease progress. Okay, so I'm going to be covering this basically under your descriptive designs and your different analytical designs. So to begin with scientific research, so the term research, we've heard it so much that it tends to freak many people out. So what we don't understand is research is what we do every day. Even if you have to buy a new mobile phone, you would like pause and see which phone is better. The camera is better in which one, which has a better battery, the processor, and all of that. That is nothing but research. So when we talk in, in terms of scientific research, it is what we do as part of our profession, that is a healthcare profession. Why do we need it? Is because this is what helps us to maintain health and fight diseases. It's only when you actively try to find out what is happening that you can actually figure out a way to either get over it or prevent it, whichever. It also helps us create new knowledge and develop different tools for using with regard to the existing knowledge. So it's the cornerstone of any decision making, and it's integral to countries' efforts as well. So from your national level, it comes into picture because they are focused on improving the health of populations. Many of us might be clinicians here, so our perspective is just limited to the patients who come into your practice. But when you look at the bigger picture, it's the health of the entire population that is at stake, which is why any research process has to be done through diligent search, proper investigations, and experimentations. So, in order to ensure that whatever discovery you do or whatever you're interpreting is actually going to benefit the entire population. So, put in simple terms, your research always starts with your research problem. So the first thing is what is it that you want to research about, or if there is something that interests you, or if you come across something new, that would be your research problem. So once you find something new, you will automatically want to go back and read up about it. You'll go online, see if or any other literature sources, your journals, textbooks, see if there's something you can find with regard to that particular condition. Say, for example, you're a clinician and you have seen 10 patients in the last 1 month who are coming to you with some sort of an oral ulceration. It's a hypothetical example. So you think you know what it is, but you're not sure. So you want to go up and read. What is it? Why is it happening? Or has it been reported? What are the sort of conditions in which from which they come from? So once you do all of that, you formulate your hypotheses. Hypothesis is nothing but a research question. And then once you decide what you want to do, you want to identify what are these oral ulcerations or lesions that are there in your patients, and you want to see if it's actually caused by something else or if it is associated with some sort of, say, a pesticide that they are using in that you don't know. So in order to find out more, you depending on what you want to find out, you design your research accordingly, which is why your research strategy and identifying the research design plays a very important role. Now, if you were interested in studying anemia and you want to see what is the prevalence of anemia or how is anemia manifested, you would obviously choose a descriptive study because it just describes, say, these are the symptoms that anemic people um, show, or this is the prevalence of anemia in this population. But if you're interested to see if anemia is somehow related to the low birth weight, the individual's birth weight, so then you would try to put in you're trying to look for some sort of relationship. So your study design will automatically change an analytical study. Now, if you know that these people are anemic and you want to see if providing iron supplements is actually going to help them, so again, your depending on your hypothesis or your aim, the approach you're going to be taking would also change. Which is why when you just use the term anemia can be studied in many ways. It all comes down to what aspect of anemia do you want to study, or which part do you want to study, which is what is your hypothesis, and depending on your hypothesis, you have to choose an appropriate research design. So once you do that, you write up your protocol, you collect all your data, and then you analyze the data to see if so the just observing all of this would not give you any result. So the idea is we put it into numbers, we convert it to numbers to have a better understanding. And if I say anemia is related to low birth weight, then you would understand that condition, and you put it behind and just on your desk, what is the whole point of doing it? And you are not actually contributing to anything. The situation is still as bad or as vulnerable as it is. So it's very important to understand actually the end research process ends when you actually put out your findings, so somebody can either read it, apply it in their country, or they can read it and build up upon it. So it's basically a blueprint or a detailed plan. It includes your different, whatever variable you're studying, that is, say, the condition that you're studying. You operationalize it so you can measure it. Then you select a specific sample, you collect data, and you analyze the results. Now, any research strategy must include what is your population of interest. Okay, it should also include what are the variables and the statuses and the relationships to each other, because it's based on this that your study design has to be selected. So there are different kinds of study designs, but it all comes down to the two basic kinds, which is an observational study and an experimental study. So the first question is the investigator intervening in the disease process? If he is not intervening, you just want to see what you're doing, like you're checking like the ground status. You're just seeing what is the condition before you actually do something. That is an observational study. So when you decide you want to do an observational study, you have to check if there's a comparison group. Now, if you go back to the example where you had 10 people in your clinic who were exhibiting an oral lesion or an ulcer, so do you want to just see what is the nature of the condition, what are its associated symptoms? If that's what you want to identify, then your choice of study would be a descriptive study where you're just describing. But if you want to see compare them with people who from the same area who do not have these lesions, you want to compare and see where is the difference or is it's associated with something else, you do an analytical studies. All analytical studies usually have a comparison group. When we talk about descriptive studies, as the name indicates, you're just describing the population. If you're talking in terms of an individual or a group of people, the studies can be your case studies and case reports. If you're talking about the population at large, it is an ecological study. When you are speaking in terms of analytical study, the next thing to look at is the direction. Now, for anything to occur, there's always a cause. So if you're trying to identify what is the cause and then check to see what effect the cause has, the design you would choose, or the most appropriate design, would be a cohort study. Now, if you already have an effect, but you want to go back and see what caused this to happen, then your choice of study would be a case control study. If you just want to see the cause and the effect as the way it is at that particular point of time, you can choose a cross-sectional study design. Now, cross-sectional study design is basically any study which is done at one particular period of time. You can have a cross-sectional analytical study, you can have a cross-sectional descriptive study. So please do not get confused with regard to that. It all depends on what is the aim of your study and or your objectives. If you're trying to look for an association between anything, it automatically becomes an analytical study. If you're doing it at one point of time, it's a cross-sectional analytical study. If you're just trying to see and describe the population, it's a cross-sectional descriptive study. So, a variation of cross-sectional studies are what we refer to as repeated cross-sectional studies. Now, this is often confused with the term longitudinal study. So, if we were to say cross-sectional studies, what is occurring at one point of time, longitudinal study is the same study which is done over a period of time. So, you have, say, you want to see how effective is behavior modification. So you collect all the first BDS students in your college, and you demonstrate or you see what is their brushing techniques. So let's say you don't demonstrate, you just ask them information regarding their brushing techniques. Okay, so this is first BDA students. Let's presume they do not know the different types of brushing techniques. So the same people you observe while they are in second year. So same questions you give them and you collect what is their information. The same thing you do in third year, the same thing you do in final year. So when you're measuring or when you're collecting information about the same people over a period of time, that is a longitudinal study. So by the time they come to final year, you can see some changes because they would have learned about different brushing techniques. Many of them would have adopted and made that change in practice. So that is a longitudinal study. A repeated cross-sectional study, however, is also what is measured over a period of time, but it is not on the same population. Now, for example, I want to see, say we're talking about a school, and I have checked what is the dental caries prevalence in that school. So we went and we checked all the students, and we got, say, a dental caries prevalence of 90%. So 90% of the students in that school um, had dental caries. So if you want to see over a period of time, if there's going to be any change in the prevalence of dental caries, you go back and you check. But even if you were to go back to the same school after 2 years, there is no guarantee that the students who were there were the same students or that particular class. There's no guarantee that the students who were in fourth standard then are still going to be in fourth standard 2 years later. But you still do an examination, check their dental caries prevalence, and you get a prevalence. Say it was say it's 92%. So the change in disease prevalence, this is what we refer to as disease trends. And you use a repeated cross-sectional study over a period of time to identify disease trends. So the difference here is in longitudinal, you're measuring it in the same group or your same study sample, whereas in repeated cross-sectional, your study sample changes. One would try to keep the remaining characteristics the same, however, but it's not the same people that you're going back and examining. So any observational study would answer 5 questions. That is, what is the condition? Who are those who are being affected by that condition? Where is this condition prevalent? When is it occurring? And why? The first 4 questions are answered by a descriptive study, whereas the why question is what is answered by an analytical study. So coming to the descriptive study designs first, it's basically the first step in your epidemiological investigations. So what do we do here? You just observe the distribution of disease in the population and you identify what characteristics the disease in question is associated with. So for example, when you had the COVID-19 um, pandemic, when it first began, so nobody knew what the situation was or what the disease was. So initially they tried to find out what are the symptoms, whom is it affecting, what are the uh, uh, of which area is it coming in from, is there any particular group of people it has a slight predilection towards. So all of this is what is answered by a descriptive study, and it is the first step. You cannot move ahead without knowing the basic idea about that particular condition, and in order to find that out you need a descriptive study. So it basically involves a collection of information, analyzing the information and interpreting it. You can use qualitative or quantitative methods, but the main focus here is just describing the condition. Okay, and you can integrate it along with other analytical methods if required, depending on the aim. But the main idea is just to describe. So when we talk about describing a disease condition, we generally speak um, three in terms of three types of description. That is the time, the place, and the person. Now, this is a characteristic feature of a descriptive study. So basically, you have your case reports, case series, and ecological studies, the 3 kinds of descriptive studies. Your case reports are what are at an individual level. So you observe, say, something different in a particular individual. It could be an unusual disease or it's an unusual association. So it would prompt further investigation or something that you would be interested in. So that is basically a case report. For example, when they first identified the first index case of COVID-19 in Bhutan, they did a case report. So basically, your unit of study is just one individual, and they checked different aspects probably in that individual, and they were able to tell, okay, although this individual is suffering from COVID-19, he's the first case in Bhutan. So what are his symptoms, or what are his presentations? What are the signs that we have noticed in him? So it's just based on one person. A lot of case reports come out if you have unusual uh, cases, even at clinics. case series is like a collection of case reports. So if you were to go back to the same example where you've seen a whole lot of oral lesions, your first person who's come to you says they have an oral lesion that you cannot typically classify it into anything we know, or an oral ulcer. So you say okay, and then you note it down and keep, and then you consistently keep saying that there are few more people who are coming in with a similar condition. So when you try to make a report on a series of cases of a specific condition, or sometimes when you're using a new treatment modality to see if it's actually effective, this becomes a case series. Case series provides a clue to an epidemic, and if there are many similar cases, it's generally a sign of an epidemic. So basically, it explains different characteristics of one group who have the same disease or the exposure. And it also helps us understand what are the demographics associated with it, how is the condition presenting, what are the prognosis and other characteristics. So this was basically how HIV was first reported when they first observed unusual pneumonia, which was present in that particular target group. So once they reported it, and eventual research led to the identification of the causative agent, saying your human immunodeficiency virus. Now, this is an example of case series where this particular author has done a whole lot of auto transplantation of teeth. So he's done it over a course of 30 years, and he's just gone ahead and published his findings, saying this is what he's done. These are the people he's treated, and this is how their outcome was. So this does not involve any sort of statistical identification or study or analyzing, and it can result in a lot of bias because it's very subjective. So these not only allow for comprehensive detailed description of the case, it also allows other practitioners to identify if somebody else in some other clinic is noticing something similar. It helps to identify. So this was basically an example of patients suffering from suprasellar meningiomas who were operated with a new technique. So what they wanted to see was what was the tumor recurrence. So they took a short period of time. They identified the time and they started noticing. When one case came back, they reported. Then many cases started coming back. Now that becomes a case series. So there are advantages. Basically, these are key hypotheses generating tools. They're simple, inexpensive, easy to conduct, and they gave you the first clue that there's something different, there's something unusual happening. But the disadvantage is they lack a comparison group, and you really cannot generalize it to everybody. That one person may have some changes. It could even be related to their genetic composition. And any association that we observe is usually and contains confounding, because there's so much of other your there are so many other uh, influences on health, your behavioral changes, social, different physical attributes. So, because none of that is taken into consideration, it can lead to confounding. I'm going to be discussing what confounding is later. So, the basic thoughts and ideas is you get simple clinical data, and it's easy to understand, and it's motivated by the intent to describe a new condition or phenomenon and could lead to the discovery of a new disease. So next, when we come to ecological studies, the focus here is not an individual, but it is an aggregate or an ecological unit. So what we do is we try to collect information regarding a particular condition or disease, whatever is what you want to study. So you collect it from a group of people who may be, and the group of people can be as small as households to as large as countries. So once you collect these, you use this information to compare health of population at different locations. Say you say what is the prevalence of malaria in India versus the prevalence of malaria, say in Pakistan. Then you also use this to generate questions and highlight issues which can fuel further research if it's in a population. Now, for example, this was the total number of cases in United States versus India versus Brazil. So when you have to make large scale comparisons like this, ecological studies provide valuable information. They have a few advantages. They are quick, easy, and very cheap to conduct. And the exposure data you are seeing at the area level. So there may be a difference in exposure between areas, and it's much bigger than what you're observing between people. So it's easier to examine. But the main disadvantage is that there's something called ecological fallacy that comes in. Then you also have systematic differences because the way COVID-19 is being assessed and recorded in one country may not match the same way it's being recorded in another country. And there's always lack of available data on confounding factors because you do not take that into consideration. Now, ecological fallacy is if you were to collect information from one house, so you have information from many houses, and you can give a conclusion regarding the area. Similarly, if you have information from many areas, you can give a conclusion regarding that whole, say, city. So when you start collecting information from an individual level, you can, depending on the methods you use, give a conclusion about the entire city, provided you have it. But if you have directly collected information about the city without paying attention to what are the information regarding the individual level, you cannot come back. I cannot go back and calculate what is, say, the prevalence of that condition in this particular housing society from the prevalence of the condition in the city. So I can't go backwards. But if you start collecting it from households and you move up, you can come to a conclusion regarding the entire city. So when we talk about descriptive studies, there are six main steps, six very simple steps that have to be followed. First is you have to define the population that you're studying, and it could be the entire population. It could be a particular area. It could be a housing society. It could be a family. So you have to basically define and describe which is that population that you're studying. It could be people of different age groups, people of different genders, and what we have to keep in mind is that it should be large enough so that it's meaningful. Now, if you have, uh, say, say the population of India, you take the population of India. Now we are in billions, 1.3 billion, if I'm not mistaken. So if you want to give a final, if you want to do a study to say what is to check the COVID prevalence of COVID-19 in India, and you take only one particular city and you give. Now, that is not going to be reflective of how it is in the entire country, right? You cannot generalize your result to the entire country. So, whichever population you take, it should be large enough so that whatever you're describing is actually meaningful. The population should be stable without migration. If you have a lot of people coming in and going out, it can potentially alter your the disease description, because what you're doing in a descriptive study is you're just describing it. And it should also be similar to other communities in that region. Then once you define your population, you're going to define the disease. So this is basically needed because you have to identify and measure disease in that particular way. So we use something called an operational definition whenever you're talking about, say you want to do a study on gingivitis. Now I have an example of gingivitis. Yeah. So we all know the definition of gingivitis is inflammation of the gingiva. But when you're actually doing your study and measuring it, you need to have a specific a definition with regard to the measurement you're doing. So my operational definition then would be gingival bleeding in one or more sites after gentle probing. Although the main definition is inflammation of gingiva, but how, when I have 20 people whom I'm examining or an entire college where I'm examining, if I have to look at inflammation of gingiva, there are certain aspects I need to look at, which are reflective of the fact that there's gingival inflammation. One of that would be gingival bleeding. So I will tell in this population in my study, I am going to identify people as having gingivitis if they have gingival bleeding in one or more sites. So if somebody else across the globe is reading my study or is reading the report or wants to reproduce it, they will exactly know how I have done my study and what was my operational definition, who were included or who were the target population in my study. If this definition is not valid, it could be a powerful source of error. And once we decide your case definition, it is it should be adhered to till the end of your study. You shouldn't alter your case definition. Then you describe the disease. This you do in terms of time, place, and person. Time can be a year, month, day, week, however. Place can be different climatic zones, different. You can start from like continents, countries, regions, oh, different states, urban and rural communities, and all of that. And person can be people belonging to different age groups, genders, different marital status, and so on. So when you talk about time distribution, there are three main types. You have diseases which have short-term fluctuations, or diseases that studies that uh, study designs which study diseases that have short-term fluctuations, periodic fluctuations, and long-term or secular trends. So when we talk about short-term fluctuations, we're looking at diseases that come from a common source or diseases that are propagated. They move from one area to another using a vector, or they're slow diseases. And when we talk about periodic fluctuations, it can be a seasonal trend or a cyclic trend. So short-term fluctuations, the classical example is an epidemic. So it's the occurrence in a community or a region of cases or an illness or any other health-related events clearly in excess of normal expectancy, and that is what an epidemic is. So we are in the midst of a pandemic, which is like a global epidemic, and these epidemics are basically uh, graphical representation is your epidemic curve. So the curve it shows the peak, it shows the incubation period, how long it's taking, if there is any decrease in the condition. So all of that can be explained in your epidemic curve. So when you talk about different types of time distributions, when you have your common source epidemics, it could be a point source or a continuous source. Now, a point source epidemic curve just has one peak and it falls. So it means, say, people have had one particular dish at a particular restaurant. So it's just one point source, and then people say end up with a gastroenteritis. So that is a point source. The source of the disease is just one point. But when you're talking about a common or a continuous source, it is when you're constantly exposed to it over a period of time. Okay, then you have propagated epidemics, which can come in short bursts and which are carried around by which involves vector transmissions. Okay? And then you have the slower modern epidemics. You have your periodic fluctuations, which are your seasonal trends or your cyclic trends. Now, for example, this was the different flus that were seen in New Delhi over a period of years. So you can see they have given what was the different types of uh, flu that was seen over a period of a year versus different years. So this is a seasonal trend. You can see every year during the rainy season, and it went up. Then you have cyclic trends. For example, influenza pandemics are actually known to occur every 7 to 10 years because there's a variation in the antigens. Or we see automobile accidents are much more frequent in weekends because you have many more people on the road who are moving. So these are cyclic trends which will happen in a cyclic manner or a repetitive. Then you have, with regard to place distribution, we have international variation where you see different patterns of disease across different countries. Now, this is a graph of the death toll in Portugal versus Spain due to COVID. Portugal and Spain are neighboring countries, but you can see there was quite a bit of difference. The shading here shows what was total excess deaths during the outbreak, and even between countries that are next to each other, there was a drastic difference. So there can be international variation, then there can be national variation. This is, for example, the map of fluoride in endemic fluoride-rich areas in India. So can have variations within a country. Then you can have rural-urban variations. Now, this is again difference in rates of uh, diseases in the urban and rural area. And then you can have local variations, which can be either within the city where the first map is a map. The first map is that of Bangalore. They had basically shared, this was the initial map, the COVID-19 containment zones. So that is variation within a city. And the second map is the famous spot map given by John Snow in the mid 1800s that actually identified uh, cholera, I mean, water from that particular pump being the source of cholera infection. You can also have migration studies. Migrant studies is extremely useful when you try to distinguish between genetic influences uh, on the development of a particular condition and environmental factors. So, if we are to study genetically similar groups but who are living under different environmental conditions, we do twin studies. And if you want to study genetically different groups but uh, living in a similar environment, I'm sorry, it's the other way around. If you're talking about genetically different groups living in a similar environment, it could be people living in different countries. Now, when you speak about person distribution, it's basically who develops the disease. This could be based on age. You have measles, which is a classic childhood disease, atherosclerosis, which is seen in older age. One important aspect that comes into picture when you're talking about person distribution is bimodality. Now, there are many diseases which can peak at two different age groups. The cause for the peaking in that particular age group may be same, may be different. This is the graph is an example of cervical cancer, which has its first peak at 43 years and second peak at 61 years. You even have Hodgkin's lymphoma, which peaks at two different age groups um, in a lifetime. Then it can be depending on the gender or the sex. Like in India, lung cancers and oral cancers are the highest cancers in male, whereas females, the highest cancers in female are your breast cancer and cervical cancer. With regard to ethnicity, we have certain ethnic groups who have a higher prevalence of sickle cell anemia due to various genetic variations. In fact, they say one in every 12 African Americans suffer from sickle cell anemia. It depends on your occupation, where you're working, and what sort of an exposure you have. It could also be based on the socioeconomic status. And we know that there's an increased prevalence of rental caries among people belonging to the lower socioeconomic groups. It could also be related to behavior, stress, and migration. So, based on any of these, depending on the aim or objective of your study, this is your person distribution. So once you study the distribution of the disease, the next thing you do is you have to measure. So the two important measurements we have is the incidence of a disease and the prevalence of a disease. So incidence basically is every new case that you see uh, among the population at risk. And prevalence is all the cases, the old cases and the new cases. So cross-sectional studies, if you are to use a cross-sectional design when you're doing a descriptive study, it gives you at that particular point how many people are suffering from that disease, which is prevalence. So at one point of time, you check, and it gives you what is the prevalence. And this you can use for chronic diseases. But if you're looking at the incidence, we need to do longitudinal studies. So longitudinal studies, when you do over a period of 5 years, will tell you how many new cases of that particular condition have been there in the last 5 years. So it gives you an idea of the incidence, and it is quite useful, but it takes much longer to do than a cross-sectional study. So once you have your information, you compare it with known indices or say previous year's values or your neighboring states' values, depending again on the aim of your study. And then you formulate a hypothesis. This is a supposition and which it is arrived at from different observations and reflections. So any epidemiological hypothesis should have 5 components, which is the population you're talking about, what is the cause that you're talking about, what is the outcome, the dose response relationship, and the time response relationship. So, for example, If we were to tell consumption of sugar causes dental caries, it gives us no idea about any of the specific groups that we're talking about, or the cause or the outcome. So a much elaborate and much clearer hypothesis would be consumption of refined sugars more than thrice daily in between meals could lead to the development of dental caries after 1 year of exposure. This is again a hypothetical situation. So here you bring in all the different aspects. So anyone who's looking at it will know who we're talking about, or what is the cause we're talking about, or what is the dose response relationship. Now, these research studies are pretty useful. It provides data regarding the magnitude of the disease load and the different types of diseases in the community. It also provides clues with regard to the etiology and helps in the formation of an hypothesis. Now, this hypothesis is what we are going to study in detail about as you move ahead with your descriptive, with your analytical studies and your experimental studies. It also gives us information, background data to plan and evaluate different services and contribute to research. So once you have completed a descriptive study design, which is telling you who, what, when, and where, you have to move the next um, study type to explain further with regard to whatever you've studied. Is your analytical study design. So it's basically, it answers the question of why and how. Your epidemiological descriptive design will only give you a hypothesis. Your analytical study is going to actually study and see if you have enough evidence to support that statement that you're making, that A is related to B, or if that is not true and it's just a random observation you have noticed in that group of people. So when we move to analytical study designs, basically, now this will tell us if there's an association between two different factors. For example, if an environmental exposure to, say, lead would result in a disease or a change in health. So if we're trying to see uh, any relationship here, we need an analytical study to give us an appropriate answer. So once we identify an association, we can then start thinking about whether the presence of lead in your surroundings was actually a cause for the condition. If we identify an association, it does not mean that it's a cause. For example, if your study tells you, say you've done a chi-square study and you have a significant p-value. So you say lung cancer is associated with smoking. Now, if you have just that much information, it is not, you cannot make a causal inference. You cannot say smoking is causing lung cancer unless you do a type of study where you're directly observing the causation. So association and causation are two different things. And if there is a causation, of course, there has to be an association. But just the presence of association is not indicative of a causal relationship. So we have three main kinds. You have your case control and cohort, classic case control and cohort studies. And you have cross-sectional analytical studies as well, where the study is just being done at one point of time. The exposure is also there in the present. The disease is also there in the present. You're just seeing if they are related to each other or not. But because you're doing it at one point of time, it's a cross-sectional study. It's analytical because you're trying to see if there's a relationship between the disease and the exposure. So it helps us to see if there's any association between the factors. And if there's an association, what is the strength of this association that is there? So the objective is to test that hypothesis which we have formed, right, at the end of your descriptive study. And the focus of your study is individuals, but you generalize your result to the population. So the first one is your cross-sectional analytical study design. Here you have your population in which the exposure is also there, the disease is also there. You're just trying to simultaneously measure it in your target population. So it measures the prevalence of the disease and it gives you a one-time snapshot. But this cannot detect any rare diseases. It cannot detect diseases that have a very short duration. And it also is not able to detect diseases which have a high case fatality, because by the time you realize and do your study, people from that disease would have already started dying. So it's most appropriate for measuring any relationship between fairly permanent characteristics in an individual to study chronic diseases and stable conditions. So what we do is we take you have your reference or your target population, you select a sample. Say you want to see if there's any association between periodontitis and hypertension. So you select your reference population, you take out a sample. So you start observing in them whether you want to see if hypertension causes or is associated with periodontitis. So the exposure here will be your hypertension. Your disease outcome would be periodontitis. So you from your sample you try to identify groups: people who have hypertension, people who don't have hypertension. These people who have periodontitis, who do not have periodontitis, and then you try to see if there's any relationship or any association between these. So it's at one point of time you have four groups in your study and you're trying to see if they're related to each other. The advantages is it starts with the reference population, because ultimately whatever conclusion you make, it has to be related or generalized to that entire population. So your sample should be a representative of your population, and here you're drawing your sample from your target population. They are short term, so they are less costly, and they can be used as starting points when you're doing a cohort study. They provide quite a bit of data, and they allow a risk assessment to be made, although it's not very precise. But they do have some disadvantages. That risk that they're seeing, people who have hypertension are at have a 2 times or 3 times higher risk. You cannot make statements like that with regard to a cross-sectional study. They're prone for bias, and since both exposure and disease are measured at the same time, you cannot establish temporality. That is, temporality is basically your time element that comes into picture. That is, you have to have hypertension in order to eventually have periodontitis. Now, if that is what we were talking about. And these cross-sectional studies do not give us or do not establish temporality. And the trend over time cannot be identified, and only association can be made. That is there any relationship between hypertension and periodontitis? Either you'll get a positive association saying yes, there is a relationship, or you may get a non-significant result. That is, there's no relationship between them. So you observing hypertension and periodontitis in the individuals may just be a random finding. So same thing I said, repeated is when you do it over a period of time with intervals, basically. The main drawback of a repeated cross-sectional study is it's difficult to see whether the change in the value you're getting every time you do is actually related to how the disease is changing over a period of time, or whether uh, there are different characteristics of the people who are a part of the study, and that's a drawback. So you can use repeated cross-sectional studies to analyze trends and to provide clues about relationships between disease and other characteristics. Also, it's useful in planning health services, because if you know how the disease is going to change, then you can plan your health service in such a way, because it takes some time. By the time you formulate and implement it, the disease manifestation would have already changed. So for you to repetitively do it, it may be a problem. So when you have a trend saying how the disease changes over a period of time, it's easier to plan. Then we have the cohort study design. It's also called a prospective study, longitudinal study, incidence, and forward-looking. The term prospective is generally misused in many places. So, for a study to be identified as a cohort study, just having a prospective element, the term prospective is looking forward, is not enough. The characteristic feature is you need to have your cohort and your comparison group. Okay, so you have to have two groups, and when two groups are not there, the study is not a cohort study, because you will not get your respective uh, analysis and values. So the main feature of a cohort study is you collect exposure data from one particular population, then you start monitoring them, and you see after how long if they're actually going to have any health changes, morbidity, mortality, or not. So it's a forward-looking study, basically. And cohort studies can be used to determine a temporal relationship. That is, if you had to have been exposed to a prior whatever exposure to actually develop the disease, and that time element can be identified in a cohort study. So what is a cohort? It's basically a group of people who share a common characteristic or experience within a defined time period. Now, this term again is a common source of confusion. Many studies use the term birth cohort, but actually are not cohort studies. It's so when just because the term cohort is present, it just means people who share a common characteristic. Just usage of the term cohort does not mean that the study is a cohort study. So a cohort study needs to have its specific features, which I'm going to be discussing ahead. So a cohort can be a birth cohort, that is people born in a specific year, can be an exposure cohort, people working in a lead factory, or a marriage cohort, people who were married in this particular year. However, so when we yeah. So there are different types of cohort studies based on the time of the disease and occurrence. So you can have prospective cohort studies, retrospective or historical cohort studies, and ambidirectional. So prospective is basically a concurrent or a longitudinal study. So you want to see if people exposed to, say, secondary smoke, tobacco smoke, actually are going to develop uh, oral cancer or lung cancer. So what you do is you have a defined population that is in whichever age group you want to see. So then based on that, you identify those people who have actually been exposed to secondhand smoke, say people who work at a restaurant where smoking is allowed. So that they form your exposed group. Your unexposed group would be people of the same characteristics or similar characteristics. The main difference being they are not exposed to secondary smoke. So maybe it could be people working in the same restaurant, probably in the non-smoking area, if we can say something like that. So the only difference should be with regard to the exposure. And then you see over a period of time, if they are actually going to develop uh, oral cancer or lung cancer or not. So you're starting from now and you're moving ahead in time. So you're going to follow them up for how many ever years. Either you put a cap on it and say 10 years, or you follow it up till there is a health event that comes up till they develop lung cancer. So you are just trying to see if being exposed to secondhand smoke is actually going to uh, cause or is going to be associated with uh, your uh, lung cancer or not. But the drawbacks is it takes a long time to complete, it's extremely expensive, and the study subjects could probably outlive the investigator. And this is why usually it is not chosen when you're starting a new research. Retrospective is you go back in time. So it's a historical or a non-concurrent prospective study. So the outcome has already started before the exposure. So what you do here is basically you're moving back in time, and you're trying to see if if people with the condition were exposed or not exposed to the particular factor that you're trying to study. It's much more economic and it gives faster details. Yeah, then you have ambidirectional. Now this can move in both ways. So you have one part where you're going back and one part where you're going front. For example, at the start of the disease, now say you have identified people with a skin rash. So you're going to go back in time to see if they were exposed to any particular factor or any chemical which could have caused the skin rash. So that's the retrospective part. You're going back, collecting information with regard to the exposure, and you're seeing if it's related to the development of the condition. And from there you move forward to see if the development of this skin rash is actually going to result in cancer, so that you're moving forward. So this is an ambidirectional cohort study. So this was a classic study, the example of the Dolan Hills prospective study on lung cancer. They studied 59,600, I mean, they got information from 59,600 British doctors, and they had 40,000 replies. So basically they sent them questionnaires to see what was their smoking habits. So they divided them into smokers and non-smokers as their uh, exposed and non-exposed group, and they followed them up till their death for the next 4 5 years or whenever, and they were able to see how much smoking was associated with the development of lung cancer. So there are different steps. The first step is your selection of study subjects. So these could either be from the general population or from your special groups. Then you obtain data either through interviews or through their medical records or medical examinations. Once you get this information, you select a comparison group. That is, people, you have to take them from the same population where you have taken your cohort. If you have taken it from a general population, from there, or from a particular people with a particular occupational background, from there. They have to be similar in all ways except for the exposure that you're studying. You can compare it internally, externally, and with general population. So while you are assembling these cohorts, the cohorts must be free from the disease, and both the groups should be susceptible to the disease. Both the groups should be comparable, and the diagnostic and eligibility criteria must be defined. So once you collect this information, you follow them up. So you follow them up and you analyze. Once you collect the result, you analyze. So the main terms of analyzing here is your relative risk and your attributable risk. You get your incidence rate. What is the incidence of this condition among the people who are exposed and people who are non-exposed? Then you estimate your relative risk. That is, what is the risk that people who are exposed are actually going to develop the disease as compared to the people who are not exposed. And so I'm just going to move a little faster. Then we have your population attributable risk. So this is in the total population, basically. The difference between your relative risk and your attributable risk is that your relative risk is better to assess the etiological role of a factor in the disease. Attributable risk reflects what is the potential of public health importance of that particular condition that you're checking. So you can do a cohort study when you have a good evidence of association, when your attrition or dropout rates can be minimized, when the exposure is rare, but the incidence rate is high, and when you have a lot of funds coming in. There are certain biases, which is an error. You can have bias in assessing the outcome, information bias. People may not respond or they may drop out because you're following them over a period of time. And they can be analytical biases. But the advantages is that you can calculate the incidence. There are several possible outcomes related to the exposure. You can provide direct estimate of relative risk, and your dose response ratios can also be calculated. But it has a number of disadvantages because you have a lot of people that are involved. You're taking a long period of time. There can be dropouts. It's expensive. You may have a lot of ethical problems coming into picture. These are the main disadvantages of your cohort study. Then you have the case control study. These are your retrospective and case reference studies, and this is what moves backwards. So you have your cases and your controls here. So the unit of study again is your individual, but the focus is the health problem, which has already occurred. So what you do here is you first identify cases and controls. So here you're moving from the disease to see whether they were exposed or not. In cohort, you're checking if they're exposed or not, and you're following them up to see if they have the disease or not. So people who have the disease are your cases. People who don't have the diseases are your controls. So you're going to go back and see what was, whether they were exposed to the factor that you're studying in your particular study, and you compare. But the feature is both exposures and outcomes have already occurred. So basically you're going backwards. You're just collecting information. You're not you're basically going back and collecting information from records. And you need a control or comparison group to either support or refute your inference. Okay, this is usually provides control group gives you a baseline on the expected amount of exposure in that population. So if your cases have a higher exposure, then you can associate the fact that they have the condition because of a higher exposure. So like I said, you're moving back in time. I mean, you're moving forward, but the direction in which you're studying is you're moving back. So there are four main elements in your case control studies. First is you select your cases and controls. Now you need to have your set diagnostic criteria and eligibility criteria, and it should not change throughout the study. So you can have your source can be from the general population or from the hospital, and the controls should also be from the same population, and they must be as similar to the cases as possible, except they shouldn't have the disease which the cases have. That is what you're trying to study, right? Whether a previous exposure has resulted in the development of the disease or not. And again, it can be the same thing. Then you have to match. So this is a process by which your controls are selected in such a way that they are like cases in all pertinent selected variables which could influence the outcome of the disease, right? So you can have group matching, you can have individual matching. So if your unit of study is say people who are like say a 45-year-old female belonging to a nuclear family with two children and things like that, your control should also be a similar group, or it can be individual characteristics. Why do we use matching? It ensures comparability between cases and controls, and it's done only for those variables which are risk factors in the disease and not a part of the investigation. It helps to nullify confounding. But there are problems. The practical problem is it's so difficult to identify an appropriate control because two people cannot be completely same. And the conceptual problem is whatever you try to compare it for, that factor like the age or the gender, that factor cannot be studied because you're comparing them, and because it's based on that's like the common factor. There can also be unplanned matching and overmatching if you try to match for so many factors. So the problem that we were speaking here, confounding, is that factor which is associated with both your exposure and the disease, but is unequally distributed in case and controls. For example, I'll give you an example. Yeah, so if you do a study and you find a relationship between increased coffee drinking and increased risk of pancreatic cancer. Now, that is what is observed, but it may not be true because increased coffee drinking may also be associated with smoking. Increased risk of pancreatic cancer is also associated with smoking. So what happens is there's a confounding factor here. So if you were to probably remove smoking, they might have or adjust for smoking. There might have been no relationship between increased coffee drinking and pancreatic cancer. And this is what happens when matching is not done properly. Again, when you can have different controls of the same type, different controls of multiple controls of different types. So once you have your cases and controls and you've matched, you measure the exposure. This could be due to interviews, questionnaires, hospital records, or whatever. And you do your final analysis. In your case control study, you get the odds ratio. Now the odds, before the odds ratio, you get your exposure rates. That will tell you among the cases, what was the exposure rate? Like 56% of the cases were exposed to, say, smoking, if you're talking about cancer. And among the controls, you calculate, say, how many of the controls were actually, controls are people who don't have the disease. So how many of the controls were actually exposed to smoking? So you have an exposure rate that you get. There you get your incidence rate, your relative risk, and your incidence rate. Here you get your exposure rate. Then to estimate what is the risk of that exposure being associated with the case or the control, you have your odds ratio. It's basically the measure of strength between a risk factor and an outcome. So you put it in a 2x2 Punnett square and you get your odds ratio, which is the ratio between odds that the case was exposed versus odds that the control was exposed. Okay, so the odds of the case being exposed basically is how many of the cases actually were exposed divided by how many of the cases were not exposed. Similarly, for the control, it's how many of the control were did have the exposure but did not develop the disease, versus how many of the controls did not have any exposure to that particular factor. An odds ratio less than 1 basically says that the exposure is negatively related to the disease. Greater than 1 is positively related. And when you have an odds ratio 1, there is no relationship between the of exposure and your disease outcome. So there are a few biases in case control studies as well. You have your bias due to confounding that can come in memory or recall because you're asking them to think and try to remember. There can be a selection bias, interviewer bias, and Birkinsonian bias. So there are a few advantages, many more as compared to cohort. It's easy to carry out, it's rapid and inexpensive. It requires comparatively lesser subjects and is suitable for rare diseases, but you won't have problems of attrition. You can identify risk factors, and it has very minimal ethical problems. But the disadvantage is that the problem of bias is much higher. Selecting an appropriate control group could be difficult because you need to have people with the same characteristics but without the particular disease. It can only give you the risk, and you cannot make any distinction between causes and associated factors. So, but it cannot be denied, however, that these studies have proven their potential value in etiological research, especially in identifying and quantifying the risk of drugs. There are other related designs, like you can have a case control in a cohort study. So you can have studies like your nested case control studies or your case cohort studies, which employ elements from both these studies. So to basically summarize the 3 different types of analytical studies, you have your cohort, case control, and cross-sectional, each of which are similar yet different, and you shouldn't just get confused. So depending on what you want to identify and what is your objective and how you want to go about it, you can choose whichever type of analytical strategy you want to, depending on what sort of risk measure you want to identify, what is your outcome, and how are you able to do it, which is why drawing up a protocol before you begin your research is very important. So to conclude, your observational studies have are of different types, and each of them are used in different conditions, and when you are trying to look for any specific relationships or trying to just describe the condition. It's the first step in the study of any diseases and can design, formulate, and analyze your hypotheses. The most ideal study is your cohort study, but the most commonly used study is your case control. And so these nested studies that I said are extremely valuable because they can combine both. And once you have a report or a result from these analytical studies that your exposure and your disease are related, that can serve as the basis for further experimental studies. These are my references. I've got a few references. Thank you. I am so sorry I have extended quite a bit of time. And yeah.
Thank you, ma'am, for a wonderful session and helping us understand the observational study